Welcome back, everyone. We now have a distinguished panel, which will be moderated by Monica Engel. And it's now my pleasure to introduce our moderator, Monica. Welcome, Monica.
Good morning, Pinar, and thank you so much. It is a pleasure to be here with everyone this morning. So just a brief introduction on...
Monica, let me just introduce you first. Sorry.
Thank you.
Thank you very much. Yeah. Thank you for the whole panel. It's so great to see all of you here. So Monica, as the Senior Vice President and President of Government Markets at Blue Cross and Blue Shield of Minnesota and CEO of Blue Plus, Monica is responsible for the organization's government health program business, which includes Medicare, Medicaid, federal employee and individual market segments. Monica Engel has more than 30 years of experience in the healthcare industry and was named one of the 2019 Women in Business honorees by the Minneapolis St. Paul Business Journal. In addition to her current experience in leading government healthcare, she has deep experience in leading public sector, Taft-Hartley Union, and commercial business. Monica was instrumental in leading the organization through the challenges of the Affordable Care Act and helping guide Minnesota seniors navigate the federally mandated sunset of Medicare cost plans. She seeks to identify new and emerging opportunities brought about by industry change, including leading the way to creation of the first health insurance retail centers in Minnesota, which continue to be a valuable resource for Minnesotans. Monica Engel holds a degree in business management and studied strategic leadership at the Kellogg School of Management and has completed the Minnesota Management Institute program from the University of Minnesota Carlson School of Management. She is a former president of the Women's Health Leadership Trust, an active member of Women Business Leaders, and a board member for the Minnesota Council of Health Plans. In 2017, the Dakota County Regional Chamber of Commerce honored Engel with a Woman of Excellence Award. In 2020, the Women's Health Leadership Trust honored her with the Jean Harris Award, which is presented to a member who advances healthcare and exemplifies the Trust's vision to create healthier communities by realizing women's leadership potential. Monica, floor is yours. We look forward to your panel.
Thank you, Pinar. And my apologies for just being eager to jump in and give the Cliff Notes version of what you just read to our participants today, as well as to our panel. It's clear, right? I share a lot of passion around this work in the healthcare industry and where we're at. And it is my honor to be here with all of you today, as well as our esteemed panel. The topic of health equity and addressing social determinants of health is so critically important for all of us. And for those of you that had a chance to hear earlier this morning, she brought a call to action for all of us. She gave us some great ideas on how to change the game and an inspirational reminder that health equity is everyone's business. So I think that's important to kick us off. As Pinar mentioned, I've been in the healthcare industry for quite some time, and I bring a little bit of a unique perspective compared to some of the other folks that have been in our discussion today, because a majority of my time in my career has been spent close to helping consumers navigate the complex healthcare industry. So as she mentioned, right, I've worked with so many sectors of the business, and there is one thing that remains constant across all lines of those business, and that is that there is a huge challenge that we have to help consumers navigate all of the systems. And Jennifer's invitation to not stay in her lane today and to work together to bring innovative ideas and creativity to address health equity and social determinants of health is so important for all of us. So I love the idea. I accept the invitation, right, as we think about how to move into each other's lanes to help think creatively and ask the tough questions. So before we jump into the panel discussion today, I'd like to ask us to pause for just a moment to address something that has been very close to home for us in Minnesota. The statement I want to read to you, and I'm going to repeat it twice just to kind of let it sink in for a moment, and that is that systemic racism is at the root cause of the significant health disparities in our country. So again, let's let that sink in for a moment. I think, when we look at the actions that are happening, and today we're here to talk about solutions and ways that we're moving this work forward. If you think and reflect back to last July, and for those of you that aren't aware, last July, the Minnesota House of Representatives passed a resolution declaring racism a public health crisis. And just prior to their actions, Blue Cross, along with many strong and influential business partners and leaders in Minnesota, joined together to stand united against acts of racism and violence. The commitment is there for the leaders of all of these wonderful organizations to come forward together toward bringing principles of greater equity, diversity, and inclusion, not only within our companies, but also within the communities in which we live and work. At Blue Cross Blue Shield of Minnesota, we have taken a pledge, as has our Blue Cross Association, and that pledge is to do more. And on behalf of all of my colleagues at Blue Cross, this work has consistently been at the core of the mission that we do in serving our members. We've made a pledge to place even stronger commitments of our words into actions. And we're seeking new ways that we can partner by engaging with provider partners like Jennifer and many others across the Twin Cities and nationwide. We're securing a seat at the table in so many areas to be helping to drive change and think differently. And I'm also extremely proud to announce that just last month, Blue Cross has announced our support to be able to bring forward the work that is tied to the new Center for Anti-Racism Health Equity at the University of Minnesota School of Public Health. Our commitment is to bring about change through our philanthropic efforts through this support. And I'd invite all of you to please make sure to follow Dr. Rachel Hardiman via social media. I'm fairly certain we will be thrilled to help support her passion and her leadership in this area. Today, I'd like to introduce three esteemed and wonderful panelists I have with me. I've had an opportunity to visit with them prior to our event today, and I think we are in for a great discussion with them and thought leaders in their work and the space that they are playing. So I will invite the audience to go ahead and submit your questions through the Q&A function on Zoom, and I'll go ahead and watch for the questions and look to weave them into our content today. But if I could, Chris Fortman, may I ask you to launch us off with introductions today?
Sure, wonderful to be here, and I'm proud to be on the screen with this group, and I'm familiar with your work and it's inspiring. So, and Monica, after your introduction, I think you could just take over as keynote. Such an impressive pathway and impact. So everyone, I am the CEO of the Minneapolis Heart Institute Foundation. I'm right here in the Phillips neighborhood at 28th in Chicago. And I really am still pausing on Monica's powerful statement about our biggest challenges and work and hope. And I'm glad and also a little intimidated that we're about the solutions, right, today. And that's exciting, and it's what we work at the Minneapolis Heart Institute Foundation. Our vision is a world without heart and vascular disease. So that's a big vision, and we are saying for all. And when we look at what we do in clinical research, educating and partnering with the community and building our own organization, there's a lot to do. There are some things I'm really excited to share with you. We're a small but mighty organization with under 100 employees, and we have over 200 studies happening that really, I hope, will move the dial. And we look forward to the different ways we're going to partner with community to move forward. And an interesting note after listening to Cara James and seeing Paurvi here and listening to what you were saying, Monica, we rely on philanthropy to do this work. 50% of our revenue comes in from doing clinical trials, so we have that, but it's the people and the organizations that really want to make a difference by investing in change that moves this work forward. So I'm really looking forward to our discussion today.
Thank you, Chris. I think you emphasize something that's so important, which is the reliance that we have on each other to help advance this work. That's so critically important. So thank you. Abner, good morning.
Morning. Thanks for the opportunity to be on the panel. My name is Abner Mason, and I'm founder and CEO for a company called ConsejoSano, which means healthy advice in Spanish. We are a patient engagement and patient navigation company. And what we're doing is trying to solve a problem that exists in our country, and it's a growing problem, that our healthcare system in the US hasn't kept up with the demographic changes that have happened in the US. The rest of society is not exactly absorbing those changes easily. Our politics, quite frankly, if we're going to be honest, have been roiled by the fact that our country is changing. It's becoming browner, and a lot of people are struggling with embracing that new America. But for those of us in healthcare, I think we have no choice but to accept and to embrace it and to figure out a way to make our healthcare system work going forward for everyone who calls this country home, not just some people. So that's my passion, is how do we bridge that gap between a healthcare system that's just not well equipped today to serve the country that we've become. So at ConsejoSano, we're using technology and a deep understanding of how different multicultural groups consume healthcare, the combination of using that technology and a lot of data with people who really understand how different types of people across the country consume healthcare is allowing us to make some great strides in helping our clients, typically their health plans, to better engage their members and to build a more trusted relationship. And those more trusted relationships lead to better health outcomes for people and lower costs for society. So I'm happy to be here and happy to talk about the work that we're doing and to learn more about all of the good things that the other panelists are working on.
That's wonderful. Thank you, Abner. And I think trust is definitely one area we're going to come back and ask you to build on for us in a little bit. Paurvi, welcome. It's a pleasure to see you. And we've had an opportunity to be at a couple of different engagements together, and the work that you are doing with the Medtronic Foundation and at Medtronic is just, it's stellar. And so we're excited to hear from you this morning. So can you give us a little bit about your background and the work that you're focused on?
Sure. Well, listen, I'm echoing what is happening across this panel, which is a bit of, aren't we lucky to be home together? I woke up this morning feeling that, and a real sense of we're home together in this. And so that is a big part of what inspires me in the work that we're doing here. I'm the president of the Medtronic Foundation. I'm the vice president of our enterprise-wide philanthropy. And one of the big things that we've done at Medtronic over the years is really focus on how do we democratize what we're doing, so that the underserved are seen in communities all around the world. There was a time when we weren't able to look in our own backyard and accept that the underserved are right here. It was just easier to decide that it was happening in someplace else. And over the years, I think we've had to come and accept that we have to shift into appreciating that segments of the population all around the world have always been left behind. And so with that in mind, we have a vision today to make sure that we have equitable access for anyone in our communities, not only in health, but also in education, because the future of what it will take to improve health is going to require both. And in order to do that well, what's our role? And certainly in trying to put more and more technology inside of healthcare, we absolutely have a role in technology. But when we're looking at what it really takes to shift into what Abner just said, which I'm so inspired by, I have to say I'm a second generation immigrant, and everything you say, no matter, and I sit in privilege, even with that, it is still a very difficult system to navigate. But in order to really shift into that, we've got to appreciate where community-based organizations are in this work. And part of the solutions are going to come and have come from that segment. So I'm excited today to talk more about that and how we've actually are shifting into a new way of thinking about philanthropy and going well beyond check writing and really getting into community and working in deep partnership with those organizations that are actually delivering directly into community and represent them well. So thank you again for the opportunity, and I'm going to learn together through this conversation.
Yes, absolutely. Well, thank you all for what you do every day. It's so critically important to the work in front of us. I'd like to go ahead and jump into questions. And again, just a reminder to the group, go ahead and place those into Q&A if you have any. But to start us out, Chris, I'd like to begin with passing my first question to you, to ask you to start us off with your thoughts. And then I'd also invite Paurvi and Abner to share their perspectives as well. But Kara had talked a little bit about this, where there are so many places that we could start. Everything from hunger to clothing, housing, transportation, and Chris, within your space, right, in condition-centric areas such as heart health and the work that you're all doing at the Minneapolis Heart Institute. Can you share with us a little bit about your thoughts on prioritization? You had referenced that you have several studies going on. As you bring this work together, what's the process or what's the work that you all are doing to think about prioritization, and where do we start?
Well, that's a big question. So, we do work from prevention to heart failure and have studies across that. And, I think that I have to say we still have to start in community, because if you look at our clinical trials and say, what is a priority we have, I think everybody's saying, what are we going to be doing differently? What are our opportunities? What will this look like a year from now? We've heard the term, we have a movement moment here, right? So it's really time to recognize. And so in the robust clinical trials and other research studies we have going on, we have a lack of representation from minority populations. We have a lack of representation of women, and we have a lack of representation from other minorities. And that is something we're really hoping to partner with industry on when they come to us with a clinical trial, and we're looking at the protocol and how we're going to enroll. So we're looking across the board, how can we do a better job? And I think the term trust has been used a lot, and rightly so. And I think, Monica, when you and I were talking, we were saying this will move at the pace of trust. So in order to have people want to participate in research, because honestly, it offers hope, it offers options that aren't otherwise there. And I think a lot of people don't even know that. So how do we get to know our community members? How do we listen? And how do we invite partnership and learning? And I'll just mention an important but small effort we're doing with North Minneapolis right now with Insight News, who also has the iHeal program. We're having conversations with community members who have heart disease, right? So, and listening and having dialogue, back and forth about how do you manage it? What is the experience? What is the question? And we're learning at how we can be a better research partner, education partner in that. So I would say our iHeal and our heart-to-heart conversations are critical. And we know we have a long way to go in who is represented in the clinical trials. In these 200 studies we have going via registries or first in human clinical trials, they're across the board. And we're part of national discussions on that. It's not just here. So it's another one of those things that I hope there's that movement around here, and we're ready and we're part of the discussions, but there's a long way to go there.
Yeah, Chris, I really enjoyed that part of our conversation last week when you had talked about, passing the mic and really moving into the communities and listening to the leaders about what we need to be focused on. I think that is so important. I know many of us are working with organizations to be able to advance that because again, we need to know what's happening in those communities to be able to understand, listen, and be able to help affect work there. So I love that work that you're doing. It's great. Paurvi or Abner, anything that you would like to add to thoughts on prioritization?
I can add very quickly, and then I think, Abner, you're going to have some things right on the ground. One of the things that has been important for us is, in order to prioritize openly, is a really important step of self-reflection. The path that we've taken, especially over the course of the last year, but I'd stretch and say it's been over the last 8 years, it follows in that democratizing health path and recognizing, every decision we make, has an implication on the entire value chain of what we're trying to do. And so the concept of prioritization needs to come first from what's our full intention, and are we really involving others along the way of our decision making? which of course involves listening, but it's also making sure that the entire value chain of how our decisions are conducted or meeting with our intentions. So for us, it's been a really important time of saying, listen, we may believe, even with our partners, that we are making the best possible decision. But once the resources leave our hands, is every hand that's touching those dollars stacked with the same intentionality all the way through to the community? And if it's not, what is it about the structure of our work that may need to change so that we're really set up to really live out what your first statement was? We're all part of a system, and that system has an architecture around it, and that architecture, indirectly or directly, may be contributing to the problem. And part of it is listening, of course, but I think some of it is also just taking a hard look. And so that has shifted in our own prioritization, but that is meant for us to do things different first, and to start to reconstruct the way we think about what impact may mean and how decisions may need to be made. And there is no solution in mind yet at all. It is just a real humble look. So I offer that because every conversation that has come forward has really been met with this deep guidance on the inside out view first. And I think each of our organizations are really taking real hold of that, and wanted to just offer the value chain pathway as a really important way to reorganize and think through priorities differently.
That's a great call out. Thank you, Paurvi. Abner, anything you'd like to add?
Just to echo the previous comments, I really think it's important, particularly when we're starting to talk about a robust response to addressing social determinants, these upstream factors, social determinants of health. I do think we need to always keep the patient or the member at the center of this. And so rather than guessing what people want, I think it's really important for us to figure out and to integrate into all of our activities, surveying, asking people what they want. Because I think what we're going to find a lot of times is that what we think people want, whether it's a patient or a plan member, is going to be very different than what they want and what they need. And so I would just want to make sure that we are prioritizing putting the patient or the health plan member at the center, and never failing to ask them. It never hurts to ask people what they want, because I think it can really help guide us going forward and make the decisions we do make and the investments we do make much more effective, because they've been informed by the people that we're trying to engage.
Yeah, I think that is so critically important. And when you and I were visiting last week, right? We've had the opportunity at Blue Cross to partner with Marnita's Table. And I will tell you, our leadership team has been engaged in those sessions, and it is so impactful, right? It's just a very, very different perspective, when you're hearing directly from, the members of the community and what they're experiencing. And we had folks get emotional, right, during those calls to say thank you for just listening and thank you for asking. So I think you're absolutely spot on with your comments, all of you, right? With just changing that dialogue, thinking differently, looking how we come forward inside out and reflect to the actions that we need to take. Well, thank you. Yesterday we heard from Dr. Sachin Jain, and we had a reminder this morning as well that we should take lessons from the civil rights movement and think about how we bring change forward. And, there's a lot of history that is ingrained into what brought us to where we are today. And so a question I'd like to ask the panel to reflect on is, what do you think needs to be different in our approach now than what we've done in the past? Paurvi, you may ask you to start us off on that one.
Sure. Well, that's a big question. I will just stretch a bit from some of my own background in the HIV movement. And that absolutely was, certainly the first pandemic of our time, but also a time when we didn't have a lot of solutions early on. It didn't come to the pace that we have now in COVID and being able to come up with solutions. And what happened then was a deep appreciation of everything we've already been talking about and the civil rights movement, of the people affected driving the change, and being enabled to, and using the structures that they rely on and pulling them into the system of decision making. And that has meant everything from supporting advocates so that they have what they need to be able to be a part of the conversations and being around the table. We can't just assume everyone's ready to be around the table. We may not even be ready to accept folks with a different perspective around the table. So really structuring, again, back to the value chain, what it takes to be able to have those voices that are needed to deliver change, and the organizations. One of the big things that was learned then, and I think throughout social change, is that the organizations closest to community are often the last ones considered when it's time to actually deliver services. So we might listen and learn about what's needed for a community member, but when it's time to actually put power of the resources in the hands of those that deliver those services, it's often last in the decision pathway. They may be a subcontractor, it might be a sub-grantee, they may not be the ones in the strategy room, they might be in the listening session. All of that, I think, is a big shift that in healthcare in particular, and I'm a health economist by training, so I'm part of the problem. My training was part of that problem. But if you look at it in a linear way, how do we bring community organizations into the engine instead of the caboose of the train? And that actually means really realizing that healthcare, the formal system of healthcare, doesn't include them. It's the informal system that we're all experiencing today when it's time to see what happens with getting vaccinated and who are we relying on. And that decision about that tends to be late in the game versus early in the game. So that's where just in looking at different movements, whether they've been due to pandemic responses or social change, we've all come back in the lessons learned to say community is what it took. And I think we have an opportunity right now to actually fuel community differently by recognizing those formal structures that sit in the informal sector, and recognize that the nonprofit sector as a sector is part of the healthcare delivery system, and what that means when we start to build back now and allow those voices in. I imagine this time next year, this panel could be different. It could actually include those folks and have them help us think through what would we do differently. And I think all of our listening will allow for that next year.
I'll just pop in if you don't mind, Monica, because Paurvi makes me think of, one of the critiques, rightly so, we often have in research is you come in, you do research, a program, you show the results, and then you leave, right? And we have, a program that has existed as an evaluation research program for 10 years, and it continues today. Now, it might be a stretch to bring to our current situation, but in New Ulm, which is a rural community and had a high rate of heart disease, we really partnered with New Ulm for a program called the Heart of New Ulm, which was led by community members. And it may have not started as community led as we wished, but it became that, and we're not part of it anymore, and that continues. And so here you have an entire population, and it just speaks to the social determinants of health, because it wasn't all about, are you checking your blood pressure, right? Are you taking your medications? It was, are you walking, and do you have safe pathways? Can your child walk to school or bike to school? Does the restaurant and or gas station offer healthy, affordable options? And, the local city council took ownership. It went into all of the workplaces, and it's a very wonderful thing to witness that we can say that their BMI is better, hypertension is managed, and they have less CV incidents than other like communities. So again, what are those learnings from something that has existed now over 10 years and is owned by the community that we can take, right? So we're anxious to look at that more closely. Is there an opportunity with our iHeal partners or others to really take this research, right, and do the same kind of success that they're seeing in New Ulm?
Chris, thank you for sharing that. We actually, you fed right into one of the questions we had received from Jordan, which is, in using that value chain model, how do you measure the values of the initiative? So that was a wonderful example. Thank you for just jumping in there. Hopefully we answered your question, Jordan. The next area I'd like to move on to, if I may, we have a question in the chat, and Abner, I'm going to ask you to start on this one just based on your comments around trust. But the question is there a prioritization to one of the largest barriers to healthcare and prevention, which is trust, which is distinctly defined by cultures and complexities within? Scott's question to us is, how do we establish trust within those communities that have been for decades underserved and borderline abused by the system? Are there various cultural brokers? Are various cultural brokers or bringing the community into the interventions the best way for us to build patient-centric models? So Abner, could I ask you to jump into that one for us? Maybe through sharing the work that you're doing and expanding beyond that.
Sure. So thanks for the question. I think one of the challenges is that our healthcare system today, as I say, it hasn't kept up with the demographic changes. What that means is that the way the healthcare system works, the way we engage patients, is we kind of treat everybody the same way. We use the same kind of engagement tool, the same message. We might translate it, usually not well, across 10 threshold languages. You work for a plan, Monica, so you're required by the state and the feds to translate it, but it's the same message. And when you engage people in that way, treat them all the same, what you're really saying is what makes them unique, what makes them special, their life journey, their experience with healthcare, their trust for the health system, the way the social determinants uniquely impact them. You're saying all those things are not important. We want you to do something, patient or plan member, and here's the way we're going to engage with you. It's kind of one size fits all. That approach, treating people like who they are, doesn't matter, because that's what you're really saying. When you say everything that's important to the patient or the member doesn't matter, and we're going to treat you all the same, we shouldn't be surprised that we don't quickly build trust. And so what we've learned at ConsejoSano, and I'll just share the lesson, it's a pretty simple lesson, is stop doing that. Stop treating people like who they are doesn't matter. And instead, let's move to a different model that we have the ability to do today, using data, a lot of data, public data, private data, claims data. We can engage people in a more customized, personalized way. It's happening all across the rest of the economy. Amazon does it and Netflix does it. They personalize. They offer different suggestions for you than they do for me. So step number one is, let's stop treating people like who they are doesn't matter, and actually customize the way we engage people in healthcare. And that's not happening today. And then step number two, it's a really important step, is we need to collect race, ethnicity, and language data. We're not doing that across our healthcare system today. It's a shame. CDC just released some data, I think yesterday or the day before. Even when it comes to vaccine distribution in 2021, given everything we know about the disparate impact of COVID on communities of color, for example, we're still not collecting race, ethnicity, and language data. That's so important because we need that data to build the baseline so that we can know how we're doing, how to invest going forward, how to measure ourselves. If you don't have metrics, you're not going to be able to measure yourselves. And if you can't measure, we're not going to have the kind of investment that we need to close healthcare disparities. So number one, we need to start treating people like who they are matters. We need more customized, personalized engagement in healthcare. And to all healthcare leaders listening, if you're not doing it, do it. Stop treating people like who they are doesn't matter. Just stop. And let's have more personalized engagement. And then number two, we need to collect, and we need policy at the federal and state level to push this. We need to collect that race, ethnicity, and language data, because that's the beginning of being able to really close gaps in care and close the healthcare disparities.
Thank you. Paurvi, any thoughts that you had on the topic?
Sure. Well, just to add to that, yes, treat people as they are. And for, it's coming back to the sector that actually reaches them first. We all know who we trust. And so really fueling those organizations, I think, matters, like I've said before. And also recognizing, I think there's some narratives out there about social determinants that, even Chris's example is a great one of, it doesn't always have to take so long to actually defend the fact that these things matter and that things can change. In the past, we would say, oh, well, if you're going to do something with a social determinant, you've got to give it a long horizon before you can see something change. And I think we're seeing plenty now that indicates that it doesn't have to take so long. And especially if you start to build the referral pathway with organizations that people already go to and trust, they're going to get the information they need. They're going to get actually the food they need, the clean water they need, the whatever other determinant you choose they need, because they've always gone there. And that needs some connecting of the dots. And we'll build trust by being able to resource those things in a way that demonstrates it. And, again, putting our money where our mouth is, but also putting our impact there, and making sure that we're not overly burdening on when we say we want to measure things. So being really refined and getting the right things, making sure that's co-designed, and making sure that information is useful back to the community. So back to civil rights and what we just discussed, that information is their information to use and continue to advocate along with us for the larger changes that we're looking for. And to make sure that that is well resourced as well. And the one piece I'll add, which I think is unique because of the corporation I'm in, I'm a part of a corporation and not a plan or part of a health system, is one of the things that we are really learning, even more so over the last year, is something that Bernice King said actually this year, that you can say anything you want in terms of the data, and we need to be tracking data here, but it's the experience that's going to change things. And it's only in the experience that change will come. And I lift that because we have 90,000 employees. And in order to change what's necessary, in society, it's not just what happens inside our four walls, it's their experience when they're outside our four walls and in the community itself. It's not just basic volunteerism, it's something very, very different. And to build trust with the community and engage in a different way means that it involves us getting directly involved. Some of that might be uncomfortable on everyone's part, but really enabling that in a way that allows for that experiential change. And, all of us have missions that we feel deeply about. I'll just say that I had to rest on ours a year ago for a minute and just make sure that I understood and what part of that mattered to me. And for us, alleviating pain, restoring health, and extending life, if we took it outside of our company and just looked at that phrase for a minute, every community wants that. Anyone who works in healthcare joined it because we wanted that. And so with that, it's a lot easier now to start the conversation in a different way. So I would just say that the trust building it actually is one person at a time, and getting involved and having grace with the discomfort sometimes of getting involved.
Yeah, probably the thought that came to my mind, right, is one of our favorites from Maya Angelou, which is, people remember how you make them feel. Right.
Absolutely.
So I think that is so critically important.
Yeah.
Love that. We do have another question coming to us from the chat, and Tom has asked a question of the panel of whether or not you have a preferred or standardized social determinants of health interoperable. Any sort of recommended tools that you'd have, or anything you'd share in the way of how you bring the work forward.
I can just say what some of our partners have done, and I think you all will have direct experience. But over the years, in trying to build the case here, so the foundation's been involved in partnerships now to build evidence for a good bit of time, community-based evidence. And so one of our partners, which is Health Finders, based out in Northfield, actually started to look at how do they get the referral chain even stronger into the health system, and started to actually record what community health workers were doing, and ensuring that the full suite of services that they offer in terms of referral was actually captured and then seen by the clinical staff that they were referring into, so that by the time you went from a household, because they're visiting a household in addition to a patient, and you see that I'll make up some options, healthy food isn't available, that is part of the medical record that then moves forward, so that when the clinician is actually seeing them, that is part of what they're also reviewing. Now, the interoperability has always been tricky, and that's outside a bit of my zone and knowing how to reconcile that. I know it's on a lot of people's mind, and how do we accelerate in there with the right kind of technology, but it needs to be actionable. Again, back to those community players, the social workers and the community health workers who are actually seeing what's going on and are able to refer back to those community groups and capture data there. This particular group with Health Finders had to create their own. They use Salesforce and kind of put something together, so they were able to do it. And it's gotten some attention, and I'm sure it'll end up being even further refined and pulled in. But I offer that as an example because it connects the dots on why community first as well. It's coming up from that vantage point, and in a time, especially in the Twin Cities, when there's so much technology. It is important to pause first and let the innovation come from the community first and see what we see. Mm-hmm.
I love what you said there. And, Abner, I'd appreciate your perspective, right? Because, you're in the work that you and your organization do, right? You're in the midst and in the action of a lot of this work. Can you give us any thoughts or ideas, right, as to how when your employees are engaging in the communities, what are some of the most successful ways in that technology, and how it's starting to be used, and what we can embrace and think differently, much to what Paurvi just shared?
Sure. I think one thing that's really exciting is that there's been a number of companies that have formed new health tech companies that are focused on the social determinants of health. At ConsejoSano, we engage the patient or the health plan member, build a trusted relationship, and get them to tell us things. It's hard to say, I don't have money to feed my kids this week, or I'm going to be put out of my house because I don't have the rent. These are not things that are easy to say. And they're not easy to say to your health plan. And I think that health plans have a big role to play here. So what we've been doing at ConsejoSano is we're hired, by our health plan partners to build that trusted relationship and get people to tell us what's happening in their lives. But telling us what's happening is an important but not sufficient step, because we need to do something about it. Once we find out, we need to do something. And that's why these companies, and I'll mention 4 that we're working with in one way or another, Unite Us and Now Pow and Healthify and Aunt Bertha, fantastic companies. All of them are building the capability of sort of meeting the needs of that patient or that member in the local community. So they build networks of community-based organizations, and they've got the technology to close the loop so that the plan can know that the person was actually helped. So we're partnering in a sort of robust way, and we actually are doing this with a large health system in New Jersey as well, with RWJ Barnabas. So it's not just plans, it's health systems that realize they need to invest in these upstream social determinant issues. So I think health plans are really important, and other stakeholders. But here's one thing I just want to add. We need to, I think the work we do is really important. We need to build that trusted relationship and find out what's happening in people's lives. We then need, these SDOH companies to solve the problem using typically community-based organizations. But one of the things we got to do is figure out how to pay those community-based organizations. It's not fair for us to all of a sudden sort of realize the importance of social determinants of health, realize the best problem solvers are community-based organizations, but not give them any funding. We're going to send people to them, but not give them funding to address those needs. Most community-based organizations probably don't have 6 months of expenses in the bank to cover their operation. So they're doing great work, but they need financial support. So we need to build out a more robust solution. But the good news is we've got players, technology companies that are coming up with great solutions. I mentioned a few, I'm sure there are others. It's working. It is really working, but we're just at the early stages. And what we need to make sure of, and this is a policy issue, that we figure out a way to fund in a much better way those community-based organizations that we depend on to actually solve these problems in the local community.
Abner, you make me think of, coming into this panel, I spoke to a few of our physicians because, we're still at this point where we're not there and there's so much work to do. And what are those big barriers? And in a research institute, a comment was, we have the data, right? We know where the gaps are, but we're not doing what we need to do with that data. So we have it. And it's the problem that you pointed out. And it's like, how do we make that happen? I think the keynote yesterday, Dr. Jane said, it's not just saying the right thing, it's doing the right thing. And we have to figure out how to do that, if it's through policy, but that funding piece is critical. And also when you mentioned Amazon and Netflix and all the different ways, of these business models that meet people where they're at, it also makes me think of the quote that of what we really need in healthcare and in this sector, and this kind of hit hard a little bit, is leadership, right? That we have enough managers, we have enough administrators, but we need leadership and people that are willing to take those strategic risks. So when we say what we hope looks different the next time we get together, I hope we can reflect on, look at these impactful strategic risks that the systems took, right, to be able to meet that. And so lots of work to do.
Mm-hmm.
I love
I
that.
think one of the risks, though, if I can jump in there, because of the community-based organizations and getting them fueled for this, right? I think there is a business model for that. I don't think that has to be philanthropic, and that's back to getting creative now and recognizing that this is a value chain that doesn't end where the plan ends or where the patient stops. It actually extends, and if you include them in the value chain and it's a part of your performance pathway, you would start to see a whole different lens of reimbursability. And that example I just gave about health finders, there's countless examples of how the sustainability of that pathway is possible. It unlocked different partnerships, certainly fueled by philanthropic resources to get the evidence in. But once it's in, then it's really up to the courageous leadership of the formal system today to say, you know what, is it really just evidence, or is it taking a chance? What's really getting in the way here? And after a while, I think it is, I agree, it is the fortitude of leadership to step in, because the work is there. And if there's some tweaking to be done, let's do it. Let's decide and do it and then get started. So I love this three-way conversation, because I think that is the next frontier. And I'd love the call to action to be, let's bring one of those folks in to this next panel a year from now, maybe sooner, because I have a feeling that they exist now, and have that discussion.
I love that idea too. Paurvi, well, you have the mic. I do have a question for you, and you touched on this briefly, but in another conference that I attended with you, you were talking about some transformative work that's taking place, in using metrics and data from the business and helping map that path forward at Medtronic and the work in your foundation. You talked a little bit about leaning into the social aspects of environmental, social, and governance work and planning that really has to be done in this space, which, to your comments, right, helps organizations understand that they need to sit at a different level of attention, and also that it brings about, I think, a more broad-based purview of what's happening within the work in ESG. So would you mind just expanding for us a little bit on that, so folks that are with us today can maybe grapple with that a little bit?
Sure. I hope I'll tell it in the same way. But ESG, for those who may not be as squarely in it day in and day out, is environment, social, and governance areas that really drive investor interest in what public and private companies should be focusing on if you're really looking for the bigger changes in society. It's a space that is helping companies appreciate their role in society. And then, and those three categories certainly have metrics and activities underneath them. And many folks probably know a lot more about the environmental area that's been there for so long. And there's some sharp metrics around that. And then the governance area hinges a bit on the trust conversation that we had earlier, but really in looking at accountability. But this S category up until this year has been the kitchen sink. It's basically everything else. And look, as long as you do a few things, certainly, and especially if you're in healthcare, my God, that's a social value, right? So of course you're doing it, right? And that was good enough in many cases. And then COVID and all of the social injustice issues that we're embroiled in came into the forefront. And it was very clear that S is now front and center, but the lack of clarity of what to do is there. It is our time. Jeff Martha, our CEO, and I had a great conversation with a whole slew of people like me, leaders in social impact inside of companies. And what was a clear call to action there is, this is our time. We say it matters. We say metrics matter. We say equity is everything. And yet we haven't really put forward what's the frame that allows us to demonstrate it and get to scale in it fast. And without that, it's going to be continue to be the kitchen sink. And so for us, what that's meant is really thinking through and unpacking what equity may mean for us. The value chain pathway that I introduced earlier was really an honest look at our role as a philanthropy, and whether we are continuing to build the system that exists today, or are we starting to dismantle parts of that? And that is really around who's making the decisions and how and why. That's the authenticity that needs to come in play. And it's taking the DEI conversation further into what we do with community. Another aspect of what we're doing that brings this to life is also noting that the nonprofit sector may be very much like how we handle supplier diversity. We're very intentional about who we move forward with in terms of our supply chain. And so why wouldn't we be in the way we think about our philanthropic resourcing as well, and what does that mean? And that will dramatically change the way things move forward. But then also looking at what we measure beyond the cosmetics of what it may appear. And if we're looking at equity and digging underneath that and are really going towards reducing disparities, then what would that actually mean? And is it just making sure that the underserved got better within themselves? Are we able to put a stake in the ground and say, no, they caught up and maybe even got better than the majority? And if we're taking that on board, now we've got social impact. And so that's the pathway that is aspirational, but one that if we are going to measure and make a difference, we're going to need to look at it from that perspective. And there is no solution in this one right now either, except to be really intentional about being clear beyond the headlines of the big words we use, which are equity, impact, right? All of these things, but what's actually going to matter underneath that. So our hope is that we'll be able to ladder that up and be able to discuss what social impact means as the S as part of ESG. And again, we're seeing it even this morning with a lot of calls for change and really positive things, but also a lot of calls saying, we don't want any more headlines of your pledges. We want to see that something happened. And so we've got to be ready for that. So that's some of the headlines of some thinking around the area. And every industry has their own mix of what's going to happen in ESG. But for us, it'll be certainly inside of healthcare and technology, but in thinking through making sure the outcomes are part of that so that we're really delivering value.
Yeah, that work is really taking the words off the paper and putting it into action. It really is. So thank you for that. We do have one question that's come through the chat, and the question brings us back to digital solutions. So the question is, how does digital literacy or lack of digital literacy in certain populations affect access, especially as technology and telehealth become a bigger part of the healthcare delivery system?
Maybe I'll just I'll start off. I think that what we have found at ConsejoSano, we are active now. We have clients across, I think, 25 or 30 states. We have some 5 or 6 of the largest Medicaid health plans that we're working with, primarily in their Medicaid line of business, but also Medicare Advantage. And what we found during the pandemic in 2020 is that a lot of low-income people didn't use these kinds of tools because they couldn't. For instance, federally qualified health centers, which is where a lot of low-income people, particularly folks on Medicaid, get their health care, they were not reimbursed for telehealth visits. And so it was not that, even though it was a wonderful tool that could have expanded access, it was not used for low-income people. It was kind of built for higher income people, and it was used for higher income people. The policies were waived during the pandemic, and FQHCs were allowed then to utilize that service. And the key point I want to make is that people used it. We generated tens and tens and tens of thousands of appointments using virtual visits or telehealth or telemedicine. So the first point I want to make is the vast majority of people, low-income people in particular, want these tools. It's just that policy has kind of prevented us from being able to use them. And then they were sometimes designed with higher income people in mind. And so they don't have a great user interface or user experience for low income people. So I think these tools are an important part of healthcare going forward. We just got to make sure that we don't let old ways of thinking cause us to prevent them from being deployed across the whole, healthcare spectrum, and so that low-income people can use them as well. But they want to, they have the ability to, and if you approach them the right way, they will use them.
Wonderful, thank you. All right, the last question I have for the panelists, and we've already touched on this through a few comments, but I'm going to ask you to dig deep and help us think about when we do come back next year, what do we think will have changed? We've talked a little bit about what we hope we'll see, but can we just spend just a couple of minutes as we look to wrap our panelist discussion today with some additional thoughts on, what do we think will have changed and what might be some signs that we're on the right track?
Well, I'd love to see that we've strengthened the referral chain to include the community-based sector, and that's become a business model that is mainstream.
And I think, it's just a kind of an obvious statement, but that we're just using plain language and we're not dancing around what social determinants of health means or who it's impacting, that it's about how we, treat everyone and provide access and care and work together. I think Abner kicked us off early on about it matters who the patient is in this system and the care that they're receiving.
And I just add, going back to policy, we're seeing now that in the Medicare Advantage program, it's the fastest growing part of Medicare. Health plans in that space are allowed to spend money, premium dollars, on upstream issues. They can buy an air conditioner for a senior in South Texas in the middle of July to prevent some sort of, breathing issue that's going to save money for the plan. So what the federal government has said is we're going to give plans some flexibility, and you can spend premium dollars on upstream issues. There is no reason why that's limited, no good reason why it's limited to Medicare Advantage, and it should be applied to Medicaid. Medicaid is the largest health program in the country. It's the program for low-income people. They have the most social determinants. They're most impacted by them. And the fact that Medicaid managed care plans across the country aren't able to have that kind of flexibility is just a shame. And we need to change that policy and give that kind of flexibility to the Medicaid program. And when you do that, you will see flourish a whole lot of solutions, because all of a sudden the plans can spend money and invest. Some of that will go to community-based organizations. Some of that will go to new technology solutions. But we have got to stop treating low-income people like they're an afterthought. So I'm really hopeful that we see that kind of flexibility that Medicare Advantage had, moved over and shared with the Medicaid program.
Wonderful, thank you. I'd like to close by thanking the panelists, and I'd also like to extend our thanks to Pinar and Kim, who have worked tirelessly with all of their colleagues at MILI to frame up a really, really solid 3-day event. There's been a lot of wonderful discussion, provocative thinking, and inspiring calls to action. So since our Health Equity Conference was inspired by Amanda Gorman and the Hill We Climb, I felt it's only fitting to end my time together with all of you to bring some additional inspiration. So one of my favorite quotes from her work is, "There is always light. And if only we're brave enough to see it, if only we are brave enough to be it." So be well, everyone. Thank you for your time and attention. And thank you to all of our panelists today.
Thanks.
Thank you so much, Monica. Thank you, Paurvi, Chris, and Abner, for this wonderful, wonderful panel session. And I want to thank all the other speakers of the day, Jennifer, Kara, and Arkel, and all the speakers we've heard all 3 days of Convene, and as well as our audience. And in addition to those of you joining us synchronously, so many people reached out to us that they couldn't join synchronously and have asked us for the recordings of the entire 3-day program. And we will make those recordings available on the conference site. And for myself, I took lots of notes throughout, but I'm really looking forward to watching them to digest all the rich material our presenters brought to us. And I really want to send my deep appreciation to all the speakers in all 3 days. Just sort of like summary points. I mean, all 3 days, our conference marked many, many important insights on drivers and solutions to prioritize health equity and the need for systems change. We started our first day of Convene with Dr. Tom Insal's remark that health does not equal healthcare, and that while we may have to define problems in a medical way, the solutions need to encompass social, environmental, and political dimensions altogether. And as he noted in the context of path to recovery in mental health, the framework around 3 Ps, people who are around us to support, place, socioeconomic conditions, and purpose, finding a mission, is I found that framework very, very useful. And then Dr. Marcela Nunez's remarks that she asked me to read on her behalf contextualized the systemic nature of the health inequities and how the pandemic has elevated and laid those bare. And she emphasized the need for better data to begin to address the social and structural determinants of health, better data collection, better measurement approaches, and better data systems to capture the socio-demographic complexity of the communities that we all serve. And her remarks also stated the importance of developing a framework for anti-racist healthcare systems and measuring patient experiences of discrimination, which is necessary and urgent towards achieving health equity and justice. And today we heard from Jennifer DeCubelis as well in her keynote calling for action to innovate and change. And she emphasized developing, again, system level solutions, following data, she said, not following just the hashtags, but defining feasible solutions and following outcomes, tracking the outcomes. And she highlighted again the systemic issue of racism in all systems, with healthcare not just being one of the exceptions, and left us with the message to be the solution. And all our conference speakers in all 3 days really centered the work in health equity that we have to do on as a social justice issue, which I wholeheartedly agree with as well. And they have also shared with us numerous examples and frameworks on how it makes so much economic sense to invest in advancing health equity, and the persistent need for innovation and the pivots from existing ways of doing things, and the importance of partnership really across the sector that we share. And on a personal note, as an immigrant myself from Turkey, who made this country my home as a first-generation American who came here on my own at age 17, and as an academic researcher, as an academic leader, I am truly, truly inspired to continue to work harder and harder in this cause. So as we conclude our program, I want to make a special shout out to MILI's program administrator, Kim Choi. MILI, Kim, if you could. Hi, Kim. She just made all of this possible, and as well as many others, MILI's graduate student assistant, Ed Walchuk, Carson School's IT team, Mary Walker, Vicky Anderson, and many other people who helped us organize the event. MILI's fantastic group of executives and residents, especially Arkel Giorgio and Julie Kemp, who helped us with the program, and MILI Student Association, Melissa, in particular, Daniel Saxton. Thank you so much. And our presenting sponsor, United Health Foundation, our gold sponsors, BIND, University of Minnesota Office of Academic Clinical Affairs, and Medtronic, and our maroon sponsors, Frederickson and Byron, Stella Care, Blue Cross Blue Shield of Minnesota, and Mayo Clinic's Robert D. and Patricia E. Kern Center for Science of Healthcare Delivery. So as I conclude, we're now ready for networking, and we can't do the networking in Zoom. We have a different platform, Hopin, for the networking, as you've seen in the chat. We encourage you to switch platforms. It takes one click, I promise, and join Hopin for the expos, to see the expos of our sponsors in MILI, and as well as networking. There are 2 different types of networking options. You could do sort of a join a group networking if you click on sessions, or you could do a one-on-one networking, randomly assigned speed dating if you click on networking. And so please join us, and thank you so, so much for the entire set of 3 days.